that? First of all, I look if there is symmetry, or if the patient is a bit asymmetrical. Is the patient slightly shifted? You know, has he got a bit of a shift, especially with acute lower back pain? Is it one side or the other? Okay. Now, also you can ask the patient without saying, so where do you feel your body weight? Is it more at the front of the toes? Is it on the heels? Or you feel that the whole foot sort of thing is on the ground? Now, people with a sway back, typically, you know what they're going to do? Their weight is going to be more on the heels. With anterior, you know, hypolordotic, maybe somewhere in between. But typically with a sway back, they're going to be more weight on the heels. Okay, so once we do that, then I look at the muscle tone. Okay, I can palpate, you know, if there is any kind of increased muscle tone unilaterally. Is it sort of increased tone more bilaterally, for example? Now, especially if it's more shifted to that side, or only tries to load that, like you will see more increased tone contralaterally. Okay. All right. So we can have a look at that. Now, also we can look at the glute size as well. People with unilateral back pain, especially if we're not loading that leg, usually going to have muscle wasting. Maybe one glute is going to be flatter compared to that side. The other things, while we're standing, we can ask the patient, can you squeeze your both glutes? Just squeeze glutes. A bit difficult. So, you know, so basically what you want to do is, so maybe out there or even over the back pain. So you squeeze and then relax. See if they can do that. Also, people with the back pain, often the glutes are inhibited. So when you have a look, can he activate glutes? Can you activate one in comparison to the other? It's a bit difficult for you, yeah? Or yeah, okay. You don't have back pain? No. All right. Good. And then you can also look at the unilateral. Can they activate one and the other? Why I do these experiments as well to show, okay, look, you know, you've got this unilateral back pain, the glutes, you cannot activate them. So I'm just building the picture. It's not a diagnosis, I'm just kind of going through this process. Certainly look at the hamstring size, not hamstring size, so you know, your thigh size, your gastroc as well. Is there any discrepancy, difference between right to left? So then from the side, what I can do, I look at the patient, so this is sort of acromion, so that's middle of acromion, and I can look at then, find the greater trochanter, yeah, on the patient. Okay, yeah. And so you look, is he in neutral, if you look at the plumb line? Is acromion over greater trochanter and lateral malleoli, or slightly sway back? And he is a bit, so it's not a lot, but slightly sway, I would say, yeah? But again, but he's asymptomatic, so it's not relevant. But if it was with pain, I want to know, can I change something, and does it change the pain? So if he was sway back and kind of really hinging a bit in the lumbar spine, I said, what about if you just shift your weight on the front of your legs? Does it change your symptoms? Because the minute you shift your weight on the front of the legs, that's going to activate your paraspinal muscles. In a sway back, they're going to inhibit it. Okay, so we can look at that. Now, other thing is, once we look at this from the side, I could look at the PSAS. So this is your PSAS, and that's your ASAS. And I look at the sort of more position of the pelvis. So he's kind of, you know, between sort of 10 and less a little bit, isn't it? Because if you look at the lumbar spine, also a bit flatter. So the natural lordosis is a bit always not there. But it's genetic, isn't it? So he doesn't have pain, that's absolutely fine. But then also why this is important, because if you've got flatter spine, you're also going to have less range of motion in the lumbar spine. So we don't expect the same range of motion as patient who has lordosis in the lumbar spine. Okay, so we look at the PSSAS, and is it more 10 to 15, so that would be considered neutral, less than 10 posterior, more than 15 going to 15, more than 15, that would be more anterior pelvic tilt. Okay, thank you. So that's that. So just quick look from the front, from the side. Now, if a patient's got, say, I have no pain, but the pain comes on maybe 1 hour of standing, or maybe 1 hour sitting, So I want to load him up a little bit and see if I can provoke their pain. So looking for that nociception. So I go from behind, even in this neutral position, what I do, I apply, guys, axial pressure. Said this, that, if I, and really putting a lot of weight. I mean, if he had pain like me, you would never do that. But if it's, you cannot, there is no pain, then I want to load them up to see, can I provoke the pain? Okay, so that would be this way. But then also, so, oh yeah, that's a bit of painful, let's say pretend it's a bit of painful. Then I say, okay, what about if you go into a bit more anterior tilt? So, okay, I said, bring your pelvis forward a bit, yeah, stay there. I will reload again. How does that feel? Or maybe better, or maybe worse. Or if I go more in a posterior tilt, softening, and load again, how does that feel? Worse or better? So I'm looking which way patient feels comfortable, okay? You can ask them, is it pain 5 or 6 or 7 out of 10? That's fine, that's okay as well. And what we know for the clinical significance, you want, you want 3 or more difference in pain. If it's only, oh, maybe it's 1, probably it's not that significant. But okay, if it was, let's say, 5 out of 10, and when I soften through here, okay, that's now 2, or it reduced dramatically. So that's, then I think, okay, posture is part of the patient's presentation, okay? But like I said, if it was a lot of pain, I will not load, I just look at that position, yeah? If you just soften through here, oh, that's a bit better, but I can still feel there's a lot of core contracting. What I also could do, I can place my hands on his rib cage, or even in supine, I can show you later as a treatment as well. They say, well, if you breathe in into my hands, into the ribs. And I said, no. So I want you to do less through the upper chest, but really, descend the diaphragm down. So really kind of getting, so just breathing into my hands. And let go. That's good. And again. So what I'm trying to do, reduce that, toning the muscles a bit, soften through there. And let's say do 10 breaths. And I said, how does it feel in your back? Well, actually feels less tension. There might be different things, maybe less pain, less tension. So I take that in consideration. Because some people, what they do when in pain, they core contract as well. And when they core contract, what happens? More load going through the spine. So I want to look, at some strategies that minimize that. Okay. Now, other things, again, after I looked at a quick posture, I said, okay, I can drop the pen. I said, look, I know in your work you have to pick up things, often, so stop it, can you pick up the pen for me? And of course he does easily, no problem. But some people, especially who are fearful of bending, remember, they're gonna do lots of weird stuff. They're gonna be core contracting. And in fact, what it does, core contraction again, more load on the spine. So it's counterintuitive. So look at that. And then I can do some modification. So if he's lots of, extension in the spine, I get them to do, okay, can you soften through the spine and do the same thing? How does it feel? In acute pain, I wouldn't do that. Again, like maybe like sprained back, I can't even bend or extend. But we're talking about maybe subacute or maybe sort of more chronic, but it's not that irritable. Then according to that, you can either load them or less load and more pain relieving, things like that. So let's say he's not that really irritable. I get you to sort of like go into this position for me, let's say, and pretend you're going like flex spine, yeah, and do elbows like this for me. Flex even more, bend your knees a bit more, yeah. So again, I can load them up, push up again, push. Does that provoke any back pain? So maybe in more functional position. And he said, no, that's okay, all right. Let's say, or maybe it was painful, so then if we do a bit more anterior tilt and slightly bend your knees a bit more, good, both knees, like a lunge, okay, and push again, how does that feel? So you can modify the pelvis position and load them up again to see which way, which way is worse, which way is better, okay, especially if he works like a physical job, but he gets either intermittent back pain or maybe has back pain, maybe low SIM, meaning like less irritability or less pain. So I try to mimic the best I can from a functional perspective as well. Do you guys have any questions on that?
How do you increase the loading sitting position?
If it's sitting, yeah. So for sitting, you can do the same. So maybe take a seat. I mean, I will lower the bed down a little bit. I'll show you how. Yeah, to make sure that the patient's feet are on the floor. Yeah, so it's comfortable. And okay, patient's got pain in sitting. So let's say you do that against a more posterior tilt. Yeah. So he sits like that, maybe forward head posture. Now I said, okay, what about if you just raise from here for me? What effect it has on your pain? Maybe I can increase the distance between the belly button and the sternum, so lift through here. Okay. So that's more relevant sometimes to the neck, or when you lift, especially if you go forward head posture as well. But what they found in studies like Wangel studies, so when you do your anterior tilt and you lift the sternum, you also get activation of your lower trapezius as well. So from postural perspective, so you can do that. And then if it's high senior, so you want to modify something. If it's not a lot of pain, then again from the front, as you see there, if I just apply a bit of pressure, and does that cause any discomfort? How does it feel compared to get neutral? The same thing you can do, again, posterior tilt, kind of thing. So load them up here, load a bit more neutral. See which way is better. So giving a bit of a direction, what might feel worse, what might feel better. And if you do this and nothing you can provoke, well, maybe, what it is? It's time. It's maybe that endurance and time, that accumulation of this. That's where you cannot necessarily produce a pain as well. But then you can advise on variability, change the positions from sitting to standing, make sure that they move out of the chair a little bit. Because sometimes it's impossible, isn't it, even because I get pain by the end of the day. So you try to load them and you may not provoke anything, but you may give a bit of advice on that.
I have a question. If let's say they have a very specific movement that will provoke pain, for example, maybe side flexion or maybe extension, like they're reaching back to get something, would you load in that angle as well? Or?
We'll show you, it's going to come next.
Oh, okay.
So we're going to look at the movement on the active combined movements. And again, we talk about irritability and pain. So if it's already a lot of pain there, I would not load. I would look what relieves the pain. So we talked about the compression and stretch. We will look at that in a second. Yeah.
How about if the aggravating factor is more dynamic or more like repetitive stuff? Would you get them to
next?
Oh, next.
We do next. Remember, so we're going to look at the posture, then we'll look at the active movements, combined movements, pivums. So it's just a beginning of an assessment at symptom modification or loading the patient depending on their pain levels. Okay, so let's try, guys. Maybe groups of 3 would be good. So one can be a patient, 2 examiners, and maybe change, and I'll come around and help you. Okay?